Hello, and welcome back to another stream of Advanced Pathophysiology. Today we're talking about Chapter 24, Structure and Function of the Reproductive System. So we'll be reading the entirety of the chapter. I know it says not to, but you know what? Let's do it. We'll jump right in. The male and female reproductive system have several anatomic and physiologic features in common. Most obvious is their major function, reproduction, through which the 23-chromosome female gamete, the ovum, and the 23-chromosome male gamete, the spermatozoon, unite to form a 46-chromosome zygote that is capable of developing a new individual. A male reproductive system produces sperm and delivers them to the female reproductive tract. The female reproductive system produces the ovum and, if it is fertilized, can nurture and protect it, and expel it at birth. These functions are determined not only by the anatomic structure, but also by complex hormonal, neurologic, and psychogenic factors. Development of the reproductive systems. The structure and function of the male and female reproductive systems depend on steroid hormones called sex hormones and their precursors. Cholesterol is the precursor for steroid hormone, including the sex hormones. Other hormones support reproduction. The action of both sex and reproductive hormones are summarized in the following table. Sex hormones, like all hormones, act on target tissues by binding with cellular receptors. See Chapter 21. Hormonal effects on the reproductive system begin well before birth and continue for life. So here's a summary of the female and male sex and reproductive hormones. A good spot to hit pause and hit review, especially if you're not familiar. As we have our dehydroepiandrosterone, your estrogens, testosterones, gonadotropin-releasing hormone, follicle-stimulating hormone, luteinizing hormone, inhibin, human chorionic gonadotropin, activin, progesterone, and relaxin. So I'll leave that up here for just a little bit so you can hit pause at the top and once at the bottom. Let's see if we can fit it all into 2 spots. Brilliant. Sexual differentiation and hormone production in utero. Initially, in embryonic development, the reproductive structures of male and female embryos are homologous, or the same, or undifferentiated. They consist of one pair of primary sex organs, or gonads, and 2 pairs of ducts, the mesonephric ducts and the paramesonephric ducts. The Müllerian ducts are the precursors of the internal female sex organs, including the oviducts, uterus, cervix, and upper vagina. Müllerian ducts are initially formed regardless of genotypic sex and require no sex-determining region on the Y chromosome. Signaling for development. The SRY signaling is required in males to cause regression of the Müllerian ducts, which in turn prevents the development of the female reproductive tract. The Wolffian ducts are the precursors of the male internal sex organs. Both pairs of ducts empty into an opening called the urogenital sinus. So here is the undifferentiated, and then it differentiates into male and female. Internal genitalia development. Again, it's a good spot to hit pause if you are needing a refresher for your anatomy and physiology. The first sign of development of reproductive organs occurs during the 5th week of gestation. Between 6 and 7 weeks gestation, the male embryo will differentiate under the influence of the testes determining factor, a protein expressed by a gene in the SRY, When the SRY gene is expressed, male gonadal development prevails. TDF stimulates the male gonads to develop into the two testes, and by 8 weeks of gestation, testosterone secretion begins. Mullerian inhibitory hormone, secreted by Sertoli cells in the testes, promotes degeneration of the Mullerian ducts. Without MIH, the Mullerian ducts would develop and the Wolffian ducts would degenerate, with loss of male sex organ development. By 9 months gestation, the male gonads have descended into the scrotum. The testes produce sperm after puberty. Female gonadal development occurs in the absence of the SRY expression and with the expression of other genes. The presence of estrogen and the absence of testosterone and MIH cause a loss of the Wolffian system, and at 6 to 8 weeks gestation, the two female gonads develop into ovaries, which will produce ova. By the 10th week, the mesonephric ducts deteriorate, and the upper ends of the paramesonephric ducts become the fallopian tubules, whereas the lower ends join to become the uterus, cervix, and upper two-thirds of the vagina. The fallopian tubes carry ova from the ovaries to the uterus during a woman's reproductive years. Lack of testosterone and the presence of estrogen promote the development of the external genitalia, the lower end of the vagina, labia, and clitoris. Like the internal reproductive structures, the external structures develop from homologous embryonic tissues. During the first 7 to 8 weeks of gestation, both male and female embryos develop an elevated structure called the genital tubercle. Testosterone is necessary for the genital tubercle to differentiate into male genitalia. Otherwise, female genitalia develop, which may occur even in the absence of ovaries, possibly because of the presence of the placental estrogens. So again, here we are looking at the undifferentiated, and then it switches at 7 weeks into male and female, and then at 10 weeks into the external genitalia in the embryonic and fetal development. Anterior pituitary gland development begins between the 4th and 5th week of fetal life, and the vascular connection between the hypothalamus and the pituitary is established by the 12th week. Gonadotropin-releasing hormone is produced in the hypothalamus by 10 weeks gestation and controls the reproduction of the gonadotropins by the anterior and pituitary gland. Your luteinizing hormone and follicle-stimulating hormone in the female fetus, the high levels of follicle-stimulating hormone and luteinizing hormone are excreted. FSH and LH stimulate the production of estrogen and progesterone by the ovary. The production of FSH and LH rises until about 28 weeks of gestation, when the production of estrogen and progesterone by the ovaries and placenta is high enough to result in the decline of gonadotropin production. Production of primitive female gametes occurs solely during fetal life. From puberty to menopause, one female gamete matures per menstrual cycle. Production of the male gametes begins at puberty, after the millions are produced daily, usually for life. By the end of pregnancy, a sensitive negative feedback system, which includes the gonadostat, is operative in the human fetus. The gonadostat responds to high placental estrogen levels by releasing low levels of GnRH, or gonadotropin-releasing hormone. Soon after birth, steroid hormones levels drop because of the withdrawal of maternal placental hormones. The hypothalamic pulsatile GnRH is secreted, and gonadotropins LH and FSH are released. The levels peak at 3 to 6 months for boys and 12 to 18 months for girls, and then fall steadily. The gonadotropins will be suppressed until the onset of puberty. Puberty and reproductive maturation. Puberty is the onset of sexual maturation and differs from adolescence. Adolescence is a stage of human development between childhood and adulthood and includes social, psychologic, and biologic changes. In girls, puberty begins at about ages 8 to 9 years of age, with thelarche, or breast development. In boys, it begins later, at about age 11, but occurs earlier with increased weight and body mass indexes. Genetics, environment, ethnicity, general health, and nutrition all can influence the timing of puberty. There is an association between obesity and early puberty in girls, perhaps from higher estrogen levels related to gonadotropin and estrogen secretion. Girls who have low body fat and reduced body weight and perform intense exercise may experience delayed maturation. Although leptin is not the trigger for puberty onset, it plays an important permissive role. Reproductive maturation involves the hypothalamic pituitary gonadal axis, the central nervous system, and the endocrine system. There is a sequential series of hormonal events that promote sexual maturation as puberty approaches. About 1 year before puberty in girls, nocturnal pulses of gonadotropin secretion and an increased response in the pituitary to GnRH occur. This in turn stimulates gonadal maturation with estradiol secretion in girls and testosterone secretion in boys. Estradiol causes development of the breasts, maturation of the reproductive organs, and deposition of fat deposits in the hips of girls. Estrogen and increased production of growth factor causes rapid skeletal growth in both boys and girls. Testosterone causes growth of the testes, scrotum, and penis. A positive feedback loop is created with gonadotropins, stimulating the gonads to produce more sex hormones. The most important hormonal effects occur in the gonads. In males, the testes begin to produce mature sperm that are capable of fertilizing an ovum. Male puberty is complete with the first ejaculation that contains mature sperm. In females, the ovaries begin to release mature ova. Female puberty is complete with the first ovulatory menstrual period. However, this can take up to 1 to 2 years after menarche. Adrenarche is the increased production of adrenal androgens before puberty, which occurs in both sexes, and is manifested by growth of axillary and pubic hair and activation of sweat and sebaceous glands. Puberty is complete when an individual is capable of reproduction. So here we're taking a look at the hormonal stimulation of the gonads, the hypothalamic pituitary gonadal axis. It's a good spot to hit pause if you're unfamiliar or need a refresher from your anatomy. The female reproductive system. The function of the reproductive system is to produce mature ova. If fertilization occurs, the female reproductive system provides protection and nourishment of the fetus until it is expelled at birth. The most important internal reproductive organ in females are the ovaries, fallopian tubes, uterus, and vagina. The external genitalia protect body openings and play an important role in sexual functioning. The external genitalia. The following figure shows the external female genitalia, which are known collectively as the vulva or pudendum. The major structures are as follows. Here's the female genitalia. Again, hit pause if you're unfamiliar or need an anatomy refresher. The mons pubis, or mons veneris, a fatty layer of tissue over the pubic symphysis. During puberty, it becomes covered with pubic hair, and sebaceous and sweat glands become more active. Estrogen causes fat to be deposited under the skin, giving the mons pubis a mound-like shape. This cushion of tissue protects the pubic symphysis during sexual intercourse. The labia majora, two folds of skin arising at the mons pubis and extending back to the fourchette, forming a cleft. During puberty, the amount of fatty tissue increases. Pubic hair grows on lateral surfaces, and sebaceous glands on hairless medial surfaces secrete lubricants. This structure is highly sensitive to temperature, touch, pressure, and pain. It is homologous to the male scrotum, and it protects the inner structures of the vulva. The labia minora. Two smaller, thinner, asymmetric folds of skin within the labia majora that form the clitoral hood and frenulum, and then split to enclose the vestibule and converge near the anus to form the fourchette. The labia minora are hairless, pink, and moist, as well as supplied with nerves, blood vessels, and sebaceous glands that secrete a bactericidal fluid that has a distinctive odor and lubricates and waterproofs the vulvar skin. The labia swell with blood during sexual arousal. The clitoris, richly innervated, erectile organ between the labia minora. It is a small, cylindrical structure having visible glands and a shaft that lie beneath the skin. The clitoris is a homologous to the male penis. It secretes smegma, which has a unique odor that may be sexually arousing to the male. Like the penis, the clitoris is a major site of sexual stimulation and orgasm. With sexual arousal, erectile tissue in the clitoris fill with blood, causing it to enlarge slightly. The vestibule, an area protected by the labia minora and contains the external opening of the vagina, called the introitus, or vaginal orifice. A thin, perforated membrane called the hymen may cover the introitus. The vestibule also contains the opening of the urethra, or urinary meatus. These structures are lubricated by two pairs of glands, Skene glands and Bartholin glands. The ducts of Skene glands open on both sides of the urinary meatus. The duct of the Bartholin gland open on either side of the introitus. In response to sexual stimulation, Bartholin glands secrete mucus that lubricates the inner labia surfaces, as well as enhances the viability and motility of sperm. Skene glands help lubricate the urinary meatus and vestibule. Secretions from both sets of glands facilitate coitus. In response to sexual excitement, the highly vascular tissue just beneath the vestibule fills with blood and becomes engorged. The perineum, an area with less hair, skin, and subcutaneous tissue, lying between the vaginal orifice and anus. Unlike the rest of the vulva, this area has little subcutaneous fat, so that the skin is close to the underlying muscle. The perineum covers the muscular perineal body, a fiber structure that consists of elastic fibers and connective tissue, and serves as the common attachment for the bulba cavernosus, the external anal sphincter, and the levator ani muscles. The perineum varies in length from 2 to 5 centimeters or more and stretches remarkably. The length of the perineum and the elasticity of the perineal body influences tissue assistance and injury during childbirth. The internal genitalia, the vagina. The vagina is an elastic fibromuscular canal 9 to 10 centimeters long in a reproductive aged female. It extends up and back from the introitus to the lower portion of the uterus. The following figure shows the vagina lies between the urethra and the rectum. Mucosal secretions from the upper genital organs, menstrual fluids, and products of the conception leave the body through the vagina, which also receives the penis during coitus. During sexual excitement, the vagina lengthens and widens, and the lower third becomes congested with blood. So here you're taking a picture of the internal female genitalia and other pelvic organs. The vaginal wall is composed of four layers, the first being mucous membrane lining. Sorry, before I get into that, here's a good spot to hit pause if you need a refresher of your anatomy. Again, if I'm ever going too quickly, please pause, pause, pause. The vaginal wall is composed of four layers. One, the mucous membrane lining the squamous epithelial cells that thicken and thins in response to hormones, particularly estrogen. The squamous epithelial membrane is continuous with the membrane that covers the lower part of the uterus. In women of reproductive age, the mucosal layer is arranged in transverse wrinkles, or folds, called rugae, that permit stretching during coitus and childbirth. The second is fibrous connective tissue containing numerous blood and lymphatic vessels, the third being smooth muscle, and the fourth connective tissue, and a rich network of blood vessels. The upper part of the vagina surrounds the cervix, the lower end of the uterus. The recess space around the cervix is called the fornix of the vagina. The posterior fornix is deeper than the anterior fornix because of the angle at which the cervix meets the vaginal canal. In most women, this angle is about 90 degrees. A pouch called the cul-de-sac separates the posterior fornix and the rectum. Its elasticity and relatively sparse nerve supply enhance the vagina's function as the birth canal. During sexual arousal, the vaginal wall becomes engorged with blood. Like the labia minora and clitoris, engorgement pushes some fluids to the surface of the mucosa, enhancing lubrication. The vaginal wall does not contain mucus-secreting glands. Rather, secretions drain into the vagina from the endocervical glands, or enter the vestibule from the Bartholin and Skene glands. Two factors help maintain the self-cleansing action of the vagina and defend it from infection, particularly during the reproductive years. They are the first, an acid-base balance that discourages the proliferation of most pathogenic bacteria, and the thickness of the vaginal epithelium. Before puberty, the vaginal pH is about 7 or neutral, and the vaginal epithelium is rather thin. At puberty, the pH becomes more acidic, 4 to 5, and the squamous epithelial lining begins to thicken. These changes are maintained until menopause, at which time the pH rises again to a more alkaline level, and the epithelium begins to thin again. Therefore, protection from infection is greatest during the years when the woman is most likely to be sexually active, between puberty and menopause. Vulnerability to infection varies somewhat with cyclic changes in pH and epithelial thickness. Both defenses are greatest when estrogen levels are high and the vagina contains a normal population of Lactobacillus acidophilus, a harmless resident bacterium that helps maintain the pH at acidic levels. Any condition that causes the vaginal pH to rise, such as douching or use of vaginal sprays or deodorants, the presence of low estrogen levels, or the destruction of Lactobacillus acidophilus via antibiotics, lowers vaginal defenses against infection. That leads us to our uterus. The uterus is a hollow, pear-shaped organ whose lower end opens into the vagina. It anchors and protects a fertilized ovum, provides an optimal environment while the ovum develops, and expels the fetus at birth. In addition, the uterus plays an important role in sexual response and conception. During sexual excitement, the opening of the uterus dilates slightly. At the same time, the uterus increases in size and moves upward and backward, creating a tenting effect in the mid-vagina that results in the cervix sitting in a pool of semen. During orgasm, rhythmic contractions facilitate movement of sperm through the cervical os, while also enhancing physical pleasure. At puberty, the uterus attains its adult size and proportions and descends from the abdomen to the lower pelvis, between the bladder and the rectum. The uterus of a mature, non-pregnant female is approximately 7 to 9 centimeters long and 6.5 centimeters wide, with muscular walls 3.5 centimeters thick. It is held loosely in position by ligaments, peritoneal tissue folds, and the pressure of adjacent organs, especially the urinary bladder, sigmoid colon, and rectum. In most women, the uterus is anteverted, that is, it is tipped forward so that it rests on the urinary bladder. However, it may be retroverted or tipped backward. Various degrees of flexion are normal. So again, here is a good spot to hit pause if you're unfamiliar with your bladder, vagina, and rectum. The uterus, whether it's midline, anteverted, anteflexed, retroflexed, or retroverted. The variations in uterine position. The uterus has two major parts, the body or corpus and the cervix. The top of the corpus, above the insertion of the fallopian tubes, is called the fundus. The diameter of the uterine cavity is widest at the fundus and narrowest at the just above the cervix, or the neck of the uterus, and extends from the isthmus to the vagina. The passage rate between the cervix upper opening and its lower opening is called the endocervical canal. The entire uterus, like the upper vagina, is innervated exclusively by motor and sensory fibers of the autonomic nervous system. So here you're taking a look at the cross-section of the uterus, fallopian tube, and ovary. Again, a good spot to pause if you need a refresher of your anatomy. The uterine wall is composed of three layers. The perimetrium is the outer serous membrane that covers the uterus. The myometrium is the thick, muscular middle layer. It is the thickest at the fundus, apparently to facilitate birth. The endometrium, or uterine lining, is composed of functional layer and a basal layer. The functional layer of the endometrium is responsive to the sex hormone estrogen and progesterone. This layer proliferates and sloughs off monthly between puberty and menopause. The basal layer, which is attached to the myometrium, regenerates the functional layer after shedding. The endocervical canal does not have an endometrial layer, but is lined with columnar epithelial cells. It is continuous with the lining of the outer cervix and vagina, which are lined with squamous epithelial cells. The point at which the two types of cells meet is called the transformation zone, or the squamous columnar junction. The transformation zone is vulnerable to the human papillomavirus, especially HPV types 16 and 18, which can lead to cervical dysplasias or carcinoma in situ. Cells of transformation zones are removed for examination during the Papinecolau or Pap smear test, which may be combined with an HPV DNA test. The cervix acts as a mechanical barrier to infectious microorganisms from the vagina. The external cervical os is a very small opening that contains thick, sticky mucus during the luteal phase of the menstrual cycle and all of pregnancy. During ovulation, the mucus changes under the influence of estrogens and forms watery strands, or spinbarkite mucus, to facilitate the transport of sperm into the uterus. In addition, the downward flow of cervical secretions moves microorganisms away from the cervix and the uterus. In women of reproductive age, the pH of these secretions is inhospitable to most bacteria. Furthermore, mucosal secretions contain enzymes and antibodies. Uterine pathophysiologic disorders include infection, displacement of the uterus within the pelvis, benign growths of the uterine wall, and hyperplasia of the endometrium, endometriosis, and cancer. So that leads us to the fallopian tubes. The two fallopian tubes enter the uterus bilaterally, just beneath the fundus. Their function is to conduct the ova from the space around the ovaries to the uterus. From the uterus, the fallopian tubes curve up and over the two ovaries. Each tube can be anywhere between 8 to 12 centimeters long and is about 1 centimeter in diameter, except at its ovarian end, which flares out like a bell on a trumpet. The vident end, called the infundibulum, is fringed and fimbriated. The fimbria move, creating a current that draws the ovum into the infundibulum. Once the ovum has entered the fallopian tube, cilia and peristalsis keep it moving toward the uterus. The ampulla, or distal third of the fallopian tube, is the usual site of fertilization. Sperm released into the vagina travel upward through the endocervical canal and uterine cavity and enter the fallopian tubes. In an ovum that is present in either tube, fertilization can occur. Whether or not the ovum encounters sperm, it continues to travel through the fallopian tube to the uterus. If fertilized, the ovum implants itself in the endometrial layer of the uterine wall. If not fertilized, the ovum breaks down within 12 to 24 hours. Disorders that affect the fallopian tubes can block the path of sperm and ovum and cause infertility or ectopic pregnancies. The ovaries. The ovaries, the female gonads, are the primary female reproductive organs. The two main functions are secretion of female sex hormones and development and release of female gametes, or ova. The almond-shaped ovaries are located on both sides of the uterus and are suspended and supported by the mesovarian portion of the broad ligament, ovarian ligaments, and suspensory ligaments. The ovaries are smaller than the male homologs, the testes. In women of reproductive age, each ovary is about 3 to 5 centimeters long, 2.5 centimeters wide, and 2 centimeters thick, and weigh anywhere between 4 to 8 grams. Size and weight vary somewhat from phase to phase of the menstrual cycle. Figure 24.8a shows a cross-section of an ovary. The central part, or medulla, is composed of connective tissue and contains many small arteries, veins, and lymphatics that enter at the hilum. Surrounding the medulla is the cortex. At birth, the cortex of each ovary contains approximately 2 million ova within primordial ovarian follicles. Follicles grow and undergo atresia continuously and irrevocably throughout a woman's life. By puberty, the number ranges between 300 to 500,000 ova. Between puberty and menopause, the ovarian cortex always contains follicles and ova in various stages of development, including the primary and secondary follicles. Once every menstrual cycle, usually only one of the follicles reaches maturation and discharges its ovum through the ovary outer covering, the germinal epithelium. During the reproductive years, 400 to 500 ovarian follicles mature completely and release an ovum. The remaining follicles either fail to develop at all or degenerate without maturation completely or maturing completely and are known as atreitic follicles. So here you're taking a look at the cross-section of ovary and the development of an ovarian follicle. After release of the mature ovum, the follicle develops into another structure, the corpus luteum. The immediate fate of the corpus luteum depends on whether the ejected ovum is fertilized. If fertilization occurs, the corpus luteum enlarges and begins to secrete hormones that maintain and support pregnancy. If fertilization does not occur, the corpus luteum secretes these hormones for approximately 14 days and then degenerates, which triggers the maturation of another follicle. The ovarian cycle, the process of follicular maturation, ovulation, corpus luteum development, and corpus luteum degeneration, is continuous from puberty to menopause, except during pregnancy or hormonal contraceptive use. At menopause, this process ceases and the ovaries atrophy to the point that they cannot be felt during pelvic examination. Sex hormones are secreted by cells present within the ovarian cortex, including two types of cells in the ovarian follicle, and granulosa and cells of the corpus luteum that primarily secrete progesterone, estrogen, and inhibin. These cells all contain receptors for the gonadotropins, or for the sex hormones, which are discussed in this section. That leads us to the female sex hormones. The sex hormones are all steroid hormones and are synthesized from cholesterol. Male and female sex hormones are present in all adults. However, the female body contains low levels of testosterone and other androgens, and the male body contains low levels of estrogen. Individuals of Individual effects of sex hormones depends on their amount and concentration in the blood. The dominant female sex hormone, estrogen and progesterone, are produced primarily by the ovaries. During fetal development, infancy, and childhood, sex hormone production is low. At puberty, hormone production surges, triggering sexual maturation and development of secondary sex characteristics. From puberty to menopause, the sex hormones control the menstrual cycle and are produced cyclically. That is, production surges and diminishes monthly, creating the ovarian and uterine changes associated with the menstrual cycle. These hormones also are produced in higher levels during pregnancy by the placenta, inhibiting ovulation. Androgens are produced in small amounts by the ovaries and the adrenals and have important functions in women. So, estrogens and androgens. Estrogen is a generic term for three similar hormones: estradiol, estrone, and estriol. Estradiol E2 is the most potent and plentiful of the three and is principally produced by the ovaries. Limited amounts are secreted by the cortices of the adrenal glands and the placenta during pregnancy. Androgens are converted into estrone in ovarian and peripheral adipose tissue. Estriol is the peripheral metabolite of estrone and estradiol. Estrogen has numerous biologic effects, many of which involve interaction with other hormones, and is needed for maturation of reproductive organs, development of secondary sex characteristics, growth, and maintenance of pregnancy. Non-reproductive effects of estrogen include closure of long bones after pubertal growth spurts, maintenance of bone and skin, and systemic organ function. After menopause, the ovaries dramatically reduce production of estradiol and secretion of estrone. At this time, the majority of estradiol is derived from intracellular synthesis in peripheral tissue. Estradiol acts locally to meet physiologic needs according to cell type and is then inactivated without systemic effects. So here in the following box is a good spot to hit pause to get a summary of the non-reproductive effects of estrogen. Like other steroid hormones, estrogen or estrogens are derived from cholesterol in a complex enzyme-mediated series of reactions. The hypothalamus secretes GnRH in a pulsatile manner that stimulates gonadotropin, released from the anterior pituitary. Gonadotropins trigger ovarian production of estrogen. The primary function of luteinizing hormone is to stimulate theca cells of the ovarian follicle to produce androgens, mainly androstenedione. Some of these androgens are converted to estrogen by the theca cells themselves, and others diffuse into granulosa cells. Within the granulosa layer, FSH induces conversion of androgens to estrogens. Estrogens are then released into the bloodstream. Estrogen and FSH together increase FSH receptors in the follicle, stimulating additional granulosa cells until a dominant follicle is determined. Although androgens are primarily male sex hormones produced by the testes, small amounts are produced in the adrenal cortex in both men and women, and in the ovaries in women. Some androgens are precursors of estrogens. At puberty, androgens contribute to the skeletal growth spurt and cause growth of pubic and axillary hair. The androgens also activate sebaceous glands, accounting for some cases of acne during puberty, and play a role in libido. Progesterone, your luteinizing hormone, from the anterior pituitary stimulates the corpus luteum to secrete progesterone, the second major female sex hormone. With estrogen, progesterone controls the ovarian menstrual cycle. Your luteinizing hormone surge occurs when there is a peak level of estrogen, about 24 to 36 hours before ovulation. Your luteinizing hormone promotes luteinization of the granulosa in the dominant follicle and results in progesterone production and the development of blood vessels and connective tissue. During the follicular phase, the ovary and adrenal glands each contribute approximately 50% of the progesterone production. Conversely, large amounts are secreted from the ovary while the corpus luteum is active for about 9 to 13 days after ovulation. The opposing and complementary effects of progesterone and estrogen are listed in the following table. Progesterone, secreted by the corpus luteum, stimulates the thickened endometrium to become more complex in preparation for implantation of a blastocyte. If conception and implantation do occur, the corpus luteum persists and secretes progesterone until the placenta is well established at approximately 8 to 10 weeks of gestation and undertakes progesterone production. So here is again a good spot to hit pause to see the complementary and opposing effects of estrogen and progesterone. Progesterone is sometimes called the hormone of pregnancy. Progesterone's effect in pregnancy include maintaining the thickened endometrium, relaxing smooth muscle in the myometrium, which prevents premature contraction and helps the uterus expand. Thickening, hypertrophy, the myometrium, which prepares it for the muscular work of labor. Promoting growth of lobules and alveoli in the breast in preparation for lactation, but preventing lactation until the fetus is born, and then promoting lactation in collaboration with prolactin after birth. Preventing additional maturation of ova by way of suppressing FSH and LH, thereby stopping the menstrual cycle. Providing immune modulation, allowing tolerance against fetal antigens, and finally preventing preterm birth. That brings us to our menstrual cycle, or the ovarian cycle. In addition to pregnancy, the obvious manifestation of female reproduction or reproductive functioning is menstrual bleeding, the menses, which starts with menarche and ends with menopause. In the United States, the median age of first menstruation is about 12, 14 years in Black females, 12.25 years in Latina or Hispanic females, and 12.6 years in white females, with ranges of 9 to 13.5 years. Menarche appears to be related to body weight, especially percentage of body fat, which may trigger a change in the metabolic rate and lead to hormonal changes associated with early menarche. There is increased circulating leptin, which promotes the secretion of kisspeptin from the hypothalamus and leads to the release of GnRH, which in turn enhances release of FSH and LH, and estradiol, triggering ovulation and the onset of puberty. Cycles are anovulatory at first and may vary in length from 10 to 60 days or more. As adolescents proceed into adulthood, regular patterns of maturation and ovulation are established at intervals ranging from 21 to 45 days. Menstruation continues to recur in a recognizable and characteristic pattern during adulthood, with the length of the menstrual cycle varying considerably among women. The commonly accepted cycle averages 28 days, with rhythmic intervals of 21 to 35 days, is considered normal. Roughly 2 to 8 years before menopause, cycles begin to lengthen again, with variation related to changing hormone levels. So, phases of the menstrual cycle. The menstrual cycle consists of two phases, the follicular proliferative phase, followed by the luteal secretory phase. During menstruation, the functional layer of the endometrium disintegrates and discharges through the vagina. Menstruation is followed by follicular proliferative phase. During the follicular proliferative phase, GnRH and a balance between activin and inhibin from the granulosa cells contribute to the rise of FSH levels, which stimulates a number of follicles. The pulsatile secretion of FSH from the anterior pituitary gland rescues a dominant ovarian follicle from apoptosis by days 5 to 7 of the cycle. Together, estrogen and FSH increase FSH receptors in the granulosa cells of the primary follicle, making them more sensitive to FSH. FSH and estrogen combine to induce production of LH receptors on the granulosa cells, thus promoting luteinizing hormone stimulation to combine with FSH stimulation, causing a more rapid secretion of follicular estrogen. As estrogen levels increase, FSH levels drop because of an increase in inhibin B secreted by the granulosa cells in the dominant follicles. This drop in FSH levels decreases the growth of less developed follicles. Estrogen causes cells of the endometrium to proliferate and stimulates production of luteinizing hormone. A surge in both FSH and LH levels is required for final follicular growth and ovulation. An increase in stromal tissue in the late follicular phase is associated with a rise in androgen levels. Androgen production enhances the process of follicle atresia, although there may be a dose-dependent support of follicle maturation. So here you're taking a look at the different stages of ovulation. The menstrual cycle, your GnRH, or gonadotropin replacing hormone. Ovulation is the release of an ovum from the mature follicle and marks the beginning of the luteal secretory phase of the menstrual cycle. The ovarian follicle begins its transformation into a corpus luteum, hence the name luteal phase. Pulsatile secretion of luteinizing hormone from the anterior pituitary stimulates the corpus luteum to secrete progesterone, which in turn initiates the secretory phase of endometrial development. Glands and blood vessels in the endometrium branch and curl through the functional layer, and the glands begin to secrete a thin glycogen-containing fluid. The secretory phase. If conception occurs, the nutrient-laden endometrium is ready for implantation. Human chorionic gonadotropin is secreted 3 days after fertilization by the blastocytes and maintains the corpus luteum once implantation occurs, at about day 6 or 7. Your human chorionic gonadotropin can be detected in maternal blood and urine 8 to 10 days after ovulation. The production of estrogen and progesterone continues until the placenta can adequately maintain hormonal production. If conception and implantation do not occur, the corpus luteum degenerates and ceases production of progesterone and estrogen. Without progesterone or estrogen to maintain it, the endometrium becomes ischemic and disintegrates, hence the name ischemic menstrual phase. Menstruation then occurs, marking the beginning of another cycle. Ovulatory cycles appear to have a minimum length of 24 to 26.5 days. The primary ovarian follicle requires 10 to 12.5 days to develop, and the luteal phase appears relatively fixed at 14 days. Menstrual blood flow usually lasts 3 to 7 days, but it may last as long as 8 days, or stops after 1 to 2 days, and still be considered within normal limits. Bleeding is consistently scant to heavy and varies from 30 to 80 ml, with most blood loss occurring during the first 3 days of menses. Menstrual discharge consists of blood, mucus, and desquamated endometrial tissue, and does not clot under normal circumstances. It is usually dark and produces a characteristic musty odor on oxidation. Environmental factors such as severe emotional stress, illness, malnutrition, obesity, and seasonal variation may affect the length of the menstrual cycle. So, hormonal control. Hormonal control of the menstrual cycle depends on complex interactions among the hypothalamus and the anterior, pituitary, and ovaries. Hormonal control is dependent on negative and positive ovarian feedback mechanisms. In the hypothalamus, kisspeptin activates the release of GnRH to stimulate the gonadotropin production of FSH and LH. The constant and pulsatile release of GnRH is critical to the timing of the menstrual cycle. GnRH is secreted into the hypophyseal portal system and travels to the anterior pituitary, where it stimulates the secretion of luteinizing hormone and follicle-stimulating hormone. FSH and LH are released from the anterior pituitary in pulses that correspond to the pulsatile secretion of GnRH. So here in this following table, we're looking at the hormonal feedback mechanism in the menstrual cycle. As always, here is a good spot to hit pause. During the early follicular phase, estrogen levels rise steadily, and through negative feedback, suppress FSH and positively increase the production of LH. During the late follicular phase, the pre-ovulatory rise in progesterone concentration facilitates the positive feedback of estrogen. Estrogen levels begin to increase, stimulating a surge of luteinizing hormone secretion from the anterior pituitary. The mid-cycle surge of LH and FSH induces ovulation. A nonsteroidal ovarian factor, gonadotropin surge attenuating factor, may antagonize the effect of estrogen on the pituitary and regulate the surge of LH at mid-cycle. Rising estrogen and progesterone levels during the luteal phase may inhibit the anterior pituitary and thus reduce LH and FSH secretion. Just before the onset of menstruation, FSH and LH levels begin to increase slightly, probably because of the declining estrogen and progesterone levels. A variety of growth factor and autocrine paracrine peptides influence hormonal control and follicular response. During the early follicular stage, FSH stimulates FSH receptors and LH receptors, and the release of insulin-like growth factor 1, as well as the production of inhibin and activin in the ovary. Activin from granulosa cells stimulates the secretion of FSH and increases the pituitary response to the GnRH and increases FSH binding in the granulosa cells in the dominant follicle. FSH stimulates inhibin secretion from the granulosa cells, and it in turn suppresses FSH synthesis. Inhibin B is primarily secreted in the follicular phase of the cycle because sharp spikes when ovulation occurs. Inhibin A is secreted in the luteal phase and further suppresses FSH. Inhibin also restrains prolactin and growth hormone release, interferes with GnRH receptors, and promotes breakdown of the intracellular gonadotropins. So, in summary, the balance between activin and inhibin regulates FSH secretion. Follistatin inhibits activin and boosts inhibin activity. Inhibin and activin also regulate luteinizing stimulation of androgen synthesis in the theca cells. The following figure in 24.9 depicts fluctuating estrogen, progesterone, gonadotropin, and inhibin levels. Research continues to advance understanding of the function and structural complexity of these polypeptides and their interaction with GnRH, gonadotropins, and sex hormones. Leading us to our ovarian cycle. By stimulating follicles, gonadotropins initiate their growth and maturation. The most important hormonal event is a rise in FSH levels. The decline in the late luteal phase of estrogen, progesterone, and inhibin secretion allows FSH levels to rise. Concurrently, there is a slight increase in LH levels. FSH stimulates granulosa cell growth and initiates estrogen production in these cells in the next cycle. At the time of group of ovarian follicles is recruited and begins to mature. The exact number depends on the remaining pool of inactive follicles. As the follicles mature, granulosa cells multiply, increasing estradiol secretion. Within a few days of the cycle, one follicle becomes dominant and the others atrophy. The mechanism for follicular recruitment or dominance is unknown. The dominant follicles begins to secrete progressively larger amounts of estrogen, which exerts an increase in GnRH receptor concentration and an increase in pituitary sensitivity to GnRH, creating a positive feedback effect causing an FSH and LH surge. Ovulation generally occurs 1 to 2 hours before the final progesterone surge, or about 12 to 36 hours after the onset of FSH and LH surge. Progesterone proteolytic enzymes and prostaglandins trigger mechanisms controlling follicular rupture and release of ovum into the fallopian tubes. The FSH and LH surge also transforms the granulosa cells of the ovulatory follicle into the corpus luteum. The corpus luteum secretes estrogen and progesterone in amounts that depend in part on adequate development of the follicle before ovulation. Progesterone acts centrally and locally within the ovary to suppress new follicular growth during the early and mid-luteal phases. If pregnancy does not occur, the corpus luteum persists for 11 to 14 days, and then regresses and eventually disappears. An increase in pulse frequency of GnRH from a low level of estrogen and progesterone reactivates hormonal control of the menstrual cycle and FSH secretion increases. The uterine phases of the menstrual cycle and the follicular proliferative phase, the luteal secretory phase, and menstruation involve cyclic changes that occur in the endometrium, controlled by estrogen and progesterone. Hormonal effects are influenced by the presence of receptors and numerous growth factors, peptides, and enzymes that act as intermediaries between the sex steroids and the endometrium. During the midfollicular phase, increasing levels of estrogen contribute to endometrial repair and proliferation, thus increasing endometrial thickness. Once ovulation occurs and serum progesterone levels increase, the endometrial tissue develops secretory characteristics. If implantation of the fertilized ovum does not take place, endometrial tissue begins to break down approximately 11 days after ovulation. Sloughing of tissue begins about 14 days after ovulation. Cervical mucus also undergoes cyclic changes. During the proliferative phase, the cervical mucus is thin and watery. Peak estrogen levels occur just before ovulation and maximally stimulate the cervical glands to produce mucus. Cervical mucus becomes abundant and more elastic. In the presence of estrogen, tiny channels develop in the mucus, which allows sperm access to the interior of the uterus. Changes in the consistency of the cervical mucus can be used to identify fertile intervals. After ovulation, the ovary begins to secrete progesterone under the influence of the corpus luteum. The amount of cervical mucus is reduced, becomes thicker and stickier, and blocks sperm migration. The vaginal response. The vaginal response. The vaginal endothelium also responds to cyclic hormonal changes of the menstrual cycle. Under the influence of estrogen, cells of the vagina epithelium grow maximally during the follicular proliferative phase. After ovulation, layers of keratinized cells overgrow the basal epithelium, a process known as cornification. Near the end of the luteal phase, leukocytes invade vaginal epithelium, removing the outer layer in a process called decornification. Body temperature. Basal body temperature, or BBT, undergoes characteristic biphasic changes during menstrual cycle in which ovulation occurs. During the follicular phase, the BBT fluctuates around 37 degrees Celsius. After the luteinizing hormone surge, the average temperature increases by 0.2 degrees to 0.5 degrees Celsius. At the end of the luteal phase, 1 to 3 days before the onset of menstruation, BBT declines to follicular phase levels. The shift in temperature is related to ovulation, corpus luteum formation, and increased serum progesterone levels. Progesterone probably acts on the thermoregulatory center of the hypothalamus to increase body temperature. Changes in BBT are used to document ovulatory cycles, but when used alone, are not the best method to predict the exact timing of ovulation. Structure and function of the breast. The adult breast lies on the ventral surface of the thorax, within the superficial fascia of the chest wall, extending vertically from the second rib to the sixth or seventh intercostal space, and laterally from the side of the sternum to the mid-axillary line. Breast tissue also may extend into the axilla. This tissue is known as the tail of Spence. The female breast. The female breast is composed of 15 to 20 pyramid-shaped lobes that are separated and supported by suspensory Cooper ligaments. Each lobe contains 20 to 40 lobules. The lobules subdivide further into many functional units called the acini. Each acinus, the singular form, is lined with a layer of epithelial cells capable of secreting milk, and an underlying layer of myoepithelial cells capable of contracting to squeeze milk from the acinus. Biochemical signaling and density within the extracellular matrix are essential for differentiation and function of the acini glandular epithelium. The acini empty into a network of lobular collecting ducts, which empty into interlobular collecting and ejecting ducts. Collagen fiber alignment is required for ductal elongation and organized branching. The ducts reach the skin through openings in the nipple. The lobes and lobules are surrounded and separated by muscle strands and fatty connective tissue. The amount of fatty connective tissue varies among individuals, depending on weight and genetic and endocrine factors, and contribute to the diversity of breast size and shape, and to the function of the mammary epithelium. Fat increases in the breast after menopause. So here is a good spot to hit pause if you need the schematic diagram of breast. Fetal and early postnatal breast tissue development does not depend on hormones, although fetal breast tissue becomes progressively responsive to hormonal stimulation. The neonatal breasts are rudimentary, containing 10 to 12 branching ducts. During childhood, breast growth is latent, and the growth of the nipple and areola keep pace with other body tissues. At the onset of puberty in the female, growth hormone, insulin-like growth factor 1, and estrogen stimulating mammary growth, breast development, or Athalarche, is usually the first sign of puberty in females. Full differentiation and maturation of breast tissue occur over approximately 4 years and are mediated by levels of a variety of hormones, including estrogen, progesterone, prolactin, growth hormone, thyroid and parathyroid hormones, insulin, and cortisol. Estrogen promotes the increase in size of the breast by the formation of mass of tissue under the areola and promotes development of the lobular ducts. The breast cells of Paris women are different than those of women who have never become pregnant, as expansion of acini only occurs with pregnancy, when the mammary gland prepares for lactation. During menopause, the lobules of the Paris breast involate to pre-pregnancy composition and become identical to the nulliparous breast. Variations in breast development are listed in box E24-1, found on Evolve. During the reproductive years, the breast undergoes cyclic changes in response to changes in the levels of estrogen and progesterone associated with the menstrual cycle. Estrogen promotes development of the lobular ducts. Progesterone stimulates development of the cells lining the acini. Lactation occurs after childbirth in response to increased levels of prolactin. Prolactin secretion, in turn, increases by continued breastfeeding. Oxytocin, another hormone released from the hypothalamus after delivery, controls milk ejection from acini cells. During the follicular proliferative phase of the menstrual cycle, high estradiol levels increase the vascularity of the breast tissue and stimulate proliferation of ductal and acinar tissue. This effect is sustained into the luteal secretory phase of the cycle. During this phase, progesterone levels increase and contribute to the breast changes induced by estradiol. Specific effects of progesterone include dilation of the ducts and conversion of the acinar cells into secretory cells. Most women experience some degree of premenstrual breast fullness, tenderness, and increased nodularity. Breast volume may increase as much as 10 to 30 ml. Because the length of the menstrual cycle does not allow for complete regression of new cells or cell growth, breast growth continues at a slow rate until approximately 35 years of age. Because of the cyclic changes that occur in breast tissue, Clinical breast examination is recommended at the conclusion of or a few days after the menstrual cycle when hormonal effects are minimal and breasts are at their smallest and least tender. During pregnancy, the breast remodels into a milk secreting organ and reaches its ultimate mature development stage. With increased levels of estrogen, the lobules further differentiate. Progesterone stimulates development of cells lining the alveoli to produce milk. Lactation occurs after childbirth in response to increased levels of prolactin. Prolactin secretion, in turn, increases by continued breastfeeding. Milk is continuously secreted into the alveolar lumen and is stored there until the myoepithelial cells are stimulated by suckling stimulation of oxytocin, which triggers the letdown reflex. The alveoli empty into a network of lactiferous ducts. These ducts reach the skin through 9 to 10 openings in the nipple. After pregnancy, the milk is continuously secreted into the alveolar lumen and is stored there until the myoepithelial cells are stimulated by oxytocin to contract, which trigger the letdown reflex. The alveoli empty into a network of lactiferous ducts. These ducts reach the skin through 9 to 10 openings in the nipple. The breast has the capacity to regress to a resting state after cessation of lactation and then undergo the same cycle of expansion and regression in subsequent pregnancies, a process possibly maintained by stem cells. This remarkable plasticity of the breast suggests tight hormonal control and dramatic tissue stromal and lobular restructuring. An extensive capillary network surrounds the acini and is supplied by perforating branches of the internal mammary, the thoracoacromial, and the internal and lateral thoracic, and the intercostal arteries. Venous return follows arterial supply, with relatively rapid emptying into the superior vena cava. The breasts receive sensory innervation from branches of the second through sixth intercostal nerves and the cervical plexus. This accounts for the fact that breast pain may be referred to the chest, back, scapula, medial arm, and neck. Lymphatic drainage from the subareolar plexus occurs largely through the axillary nodules, but there may be a predominance of superficial mammary routes, with resultant asymmetry between the person's breasts. So here we're taking a look at the lymphatic drainage of the female breast. Again, a good spot to hit pause if you need a review of your anatomy. The nipple is a pigmented, cylindrical structure, usually located at the fourth or fifth intercostal space. On its surface lie multiple openings, one from each lobe. It measures 0.5 to 1.3 centimeters in diameter and is approximately 10 to 12 millimeters in height when erect. The areola is the pigmented circular area in the center of the breast, surrounding the nipple. It may be 15 to 60 millimeters in diameter. A number of sebaceous glands, the glands of the Montgomery, are located within the areola and aid in lubrication of the nipple during lactation. The nipple and the areola contain smooth muscle that receive motor innervation from the sympathetic nervous system. Breastfeeding, sexual stimulation, and exposure to cold cause the nipple to become erect. The function of the female breast is primarily to provide a source of nourishment for the newborn. Physiologically, breast milk is the most appropriate nourishment for newborns. Colostrum, produced in low quantities in the first few days postpartum, is rich in immunologic components including secretory IgA, lactoferrin, leukocytes, and developmental factors, such as epidermal growth factor. The nutrient composition changes over time to meet the changing digestive capabilities and nutritional requirements of the infant. Secretory IgA and nonspecific antimicrobial factors, such as lysosomes and lactoferrin, protect the infant against infection. During lactation, high prolactin levels interfere with hypothalamic pituitary hormones that stimulate ovulation. This mechanism suppresses the menstrual cycle and can prevent ovulation. In some parts of the world, breastfeeding is a major means of contraception. However, it is not absolute that ovulation will not occur, and this method will not ensure that pregnancy will not occur. Breasts also are a source of pleasurable sexual sensation and, in the Western culture, have become a sexual symbol. The male breast. Until puberty, development of the male breast is similar to that of the female breast in the absence of sufficiently high levels of estrogen and progesterone. The male breast does not develop any further. The normal male breast consists of a small underdeveloped nipple, some fatty and fibrous tissue, and a few duct-like structures in the subareolar area. The male breast may appear enlarged in obese men because of the accumulation of fatty tissue. During puberty, some males experience benign gynecomastia, a condition in which the breasts enlarge temporarily as a result of hormonal fluctuations and should be differentiated from any underlying systemic disorders. The male reproductive system, the external genitalia in men, perform the major functions of reproduction. Sperm are produced in the male gonads, the testes, and delivered by the penis to the female vagina. The internal male genitalia consist of conducting tubes and fluid-producing glands, all of which aid in the transport of sperm from the testes to the urethral opening of the penis. The male reproductive and urinary structures are shown in the following figure. So if you need a refresher for your anatomy, go ahead and hit pause. The external genitalia, the testes. In men, the testes are the essential organs of reproduction. Like the ovaries, the testes have two functions: production of gametes and production of sex hormones. During the embryonic and fetal life, the testes develop within the abdomen. About 3 months before birth, the testes start to descend toward the developing scrotum. About 1 month before birth, they enter twin passageways called inguinal canals. The inguinal canals are vaginal processes created by outpouchings of the peritoneum. The descent of the testes is shown in the following figure. Each testes moves down outside the peritoneum until it is suspended in the scrotal sac by its supply lines, the ducts, blood vessels, lymphatic vessels, and nerves of the spermatic cord. When descent is complete, the abdominal end of each vaginal process closes and the inguinal canal disappears. If peritoneal closure at the site of the inguinal canal is incomplete or weak, an inguinal hernia may occur later in life. The scrotal end of each vaginal process becomes the outer covering of the testes. The tunica vaginalis, failure of the testes to descend through the inguinal canal, is known as cryptorchidism. So here we're taking a look at the formation of the inguinal canal and the descent of the testes. So again, if you need a refresher for your anatomy, physiology, good spot to hit review. The following figure shows the sagittal section of the mature testes. The adult testes is ovoid and varies considerable in length, width, and weight. The testes is almost entirely surrounded by an outer covering, the tunica vaginalis, which separates the testes from the scrotal wall, and an inner covering, the tunica albuginea. Inward extension of the tunica albuginea forms septa that separates the testes into about 250 compartments or lobules, each of which contains several tortuously coiled ducts called semi-nefarious tubules. The semi-nefarious tubules constitute the bulk of the testicular volume and are the site of sperm production. Spermatogenesis is described under the section titled Spermatogenesis. Tissue surrounding these ducts contains blood and lymphatic vessels, fibroblastic support cells, macrophages, mast cells, and Leydig cells. Leydig cells occur in clusters and produce androgen, chiefly testosterone. So here you're taking a look at the testes. Again, a good spot to hit pause if you need to review. The two ends of each seminefarious tubule join and leave the lobule through the short, straight section called the tubulus rectus. Sperm travel from the seminefarious tubules into these straight sections, which lead to the central portion of the testes. The rete testes. From the rete testes, sperm move through the efferent tubules, or vasa efferentia, to the epididymes, where they mature. The testes are innervated by adrenergic fibers, whose sole function is to regulate blood flow to the Leydig cells. Arterial blood from the internal spermatic and differential arteries flows over the surface of the testes before entering the parenchyma. Surface flow cools the blood to temperatures that promote spermatogenesis, roughly 2 to 7 degrees Celsius, below body core temperature. Additionally, the testes are suspended outside the pelvic cavity to facilitate cooling. The epididymes is a comma-shaped structure that curves over the posterior portion of each testes. It consists of a single, highly packed and markedly coiled duct, measuring 5 to 7 centimeters in length. The epididymis has structural and physiologic functions. Its structural function is to conduct sperm from the efferent tubules to the vas deferens, whereas physiologic functions include sperm maturation, mobility, and fertility. When sperm enter the head of the epididymis, they are not fully mature or motile, nor are they capable of fertilizing an ovum. During the 12 days sperm take to travel the length of the epididymis, they receive nutrients and testosterone from the epididymal epithelium, and their capacity for fertilization is enhanced. After traveling the length of the epididymis, sperm are stored in the epididymal trail, which is continuous with the vas deferens. The vas deferens is a duct with a muscular layer capable of powerful peristalsis that transports sperm toward the urethra. The vas deferens enters the pelvic cavity through the spermatic cord. That brings us to the scrotum. The testes, epididymis, and spermatic cord are enclosed and protected by the scrotum, a skin-covered fibromuscular sac that is homologous to the female labia majora. The skin of the scrotum is thin and has rugae that enable it to enlarge or relax away from the body. At puberty, the scrotal skin darkens, develops active sebaceous glands, and becomes sparsely covered with hair. Just under the skin lies a layer of connective tissue and smooth muscle, the tunica dartos. The tunica dartos also forms a septum that separates the two testes. Exposure to cold temperatures causes the tunica dartos to contract, pulling the testes close to the warm body. In warm temperatures, the tunica dartos relaxes, suspending the testes away from the body heat. These mechanisms promote optimal temperature for spermatogenesis. In addition, scrotal sensitivity to touch, pressure, temperature, and pain protects the testes against potential harm. During sexual excitement, the scrotal skin and tunica thicken, the scrotum tightens and lifts, and the spermatic cord shortens, partially elevating the testes toward the body. As excitement pleates, the engorged testes increase 50% in size, rotate anteriorly, and flatten against the body, signaling impending ejaculation. The penis. The penis has two main functions: delivery of sperm to the female vagina and elimination of urine. Embryonically, the penis is homologous to the female clitoris. The following figure shows a sagittal section at the adult penis and its anatomic relation to the urogenital structures. Externally, the penis consists of a shaft with a tip, or the glans, that contains the opening of the urethra. The skin of the glans folds over the tip of the penis, forming the prepuce, or foreskin. At birth, the foreskin is adhered to the glans. Penile erections, which commonly occur, cause the adhesions to break so that by the age of 3, the foreskin becomes completely retractable. The skin of the penis is continuous with that of the groin, scrotum, and inner thigh. It is hairless, movable, and darker than the surrounding skin. So here you're taking a look at a penis, which is a cross-section of the penis. Internally, the penis consists of the urethra and the three compartments, two corpora cavernosum and the corpus spongiosum, separated by buccal fascia. Like the testes, these compartments are enclosed by the fibrous tunica albuginea. The urethra passes through the corpus spongiosum and ends at the sagittal slit in the glans. Penetration of the female vagina is made possible by the erectile reflex, a process in which erectile tissue within the corpora cavernosa and corpus spongiosum become engorged with blood, roughly about 20 to 50 ml. The erectile tissue consists of vascular spaces or chambers that are supplied with blood by arterioles. Typically, arterioles are constricted through tonic noradrenaline release from the sympathetic nerves, so that small amounts of blood flow through the erectile tissue. Sexual stimulation, however, causes the arterioles to dilate through release of nitric oxide and fill with blood, expanding the erectile tissues and causing an erection. Other central transmitters, such as dopamine and acetylcholine, are facilitators of erectile control as well. Erection apparently is maintained by compression or constriction of veins that drains the corpora cavernosa and corpus spongiosum. When sexual stimulation ceases, or orgasm and ejaculation occur, the veins open, blood flows out of the arterioles, and the penis becomes flaccid. Erection under control of the autonomic nervous system, but can be stimulated or inhibited by central nervous system input. Stimulation of mechanoreceptors of the penis, particularly of the glans, causes parasympathetic nerves of the autonomic nervous system to relax, smooth muscle in the walls of the penile arterioles. At the same time, the effects of the sympathetic nerves, which normally cause arterial smooth muscle to constrict, are inhibited. Erections begin in utero and continue throughout life, but ejaculation does not occur until sperm production begins at puberty. Growth of the penis and scrotal contents continues well past puberty, however, and may not be complete until the late teens or early 20s. Penis size, when flaccid, varies considerably. With an erection, differences in penis size diminish. Sexual excitement causes the corpora cavernosa to increase in length and width and become rigid. The penis becomes erect. Stimulation of the glans, which is endowed with copious sensitive nerve endings, provides maximum erotic sensation. With sexual arousal, skin color deepens, the glans doubles in size, and the urethral meatus dilates. Ejaculation occurs with frequent, strong contractions of the vas deferens, epididymis, seminal vesicles, prostate urethra, and penis. Erection and ejaculation can occur independently of each other, but it is not common. So, the internal genitalia. Figure 2413 shows the anatomy of the internal genitalia and their relation to other pelvic organs. The internal genitalia consists of ducts and glands as follows. So the ducts consist of two vasa deferentia, the, the ejaculatory duct and the urethra. Conduct sperm and glandular secretions from the testes to the urethral opening of the penis. And then the glands, which consist of the prostate gland, two seminal vesicles, and two Cowper glands, which secrete fluids that serve as the vehicle for sperm transport and create an alkaline, nutritious medium that promotes sperm motility and survival. Together, the sperm and the glandular fluids comprise semen. Sperm leave the epididymis and travel rapidly through the internal ducts in a process called emission. Emission occurs just seconds before ejaculation, at that moment when sexual arousal peaks. It always leads to ejaculation. Emission occurs as smooth muscle in the walls of the epididymis and vasa deferentia begins to contract rhythmically, pushing sperm and the epididymal secretions through the vasa deferentia. Each vas deferens is a firm, elastic, fibromuscular tube that begins at the tail of the epididymis, enters the pelvic cavity within the spermatic cord, loops up and over the bladder, and ends in the prostate gland. Sperm are moved along the peristaltic contractions of smooth muscles in the walls of the vas deferens. So here is a great spot, excuse me, a great spot to hit pause if you need to review the zones of the prostate gland and seminal vesicles. As sperm leave the ampulla of the vas deferens, the seminal vesicles secrete a nutritive, glucose-rich fluid into the ejaculate. The seminal vesicles are a pair of glands, each about 4 to 6 centimeters long, that lie behind the urinary bladder and in front of the rectum. The seminal vesicles provide fructose as a source of energy for ejaculated sperm and secrete prostaglandins that promote smooth muscle contraction. Assisting with sperm transport, the ducts of the seminal vesicles join the ampulla of the vas deferens to become the ejaculatory duct, which contracts rhythmically during emission and ejaculation, as can be seen in Figure 2412 and 2416. The ejaculatory duct joins the urethra, where both pass through the prostate gland. During emission and ejaculation, a sphincter closes, preventing urine from entering the prostatic urethra. The prostate gland is about the size of a walnut, has 3 zones, and surrounds the urethra. It is composed of glandular alveoli and ducts embedded in fibromuscular tissue. Prostate growth, development, and function are regulated by androgens and the androgen receptor. Nerves required for penile erection travel along the posterolateral surface of the prostate. Included in prostate epithelial secretions are prostate-specific antigens, cytokeratins, prostate-specific membrane antigens, and prostate-specific acid phosphatases. Prostate secretions contribute to the ejaculate. While semen moves through the prostatic portion of the urethra, the prostate glands contract rhythmically and secretes prostatic fluid into the mixture. Prostatic fluid is a thin, milky substance with an alkaline pH that helps sperm survive in the acidic environment of the female reproductive tract. In addition, clotting enzymes and fibrinolysin in prostatic fluids helps mobilize sperm after ejaculation. The Cowper glands are the last pair of glands to add fluid to the ejaculate. Their ducts secrete mucus into the urethra near the base of the penis. Ejaculation occurs as semen reaches the base of the penis and muscles. There begin the rhythmic contractions that expel semen. A man normally ejaculates between 2 and 6 ml of semen, containing 75 million to 400 million sperm. About 98% of the ejaculate consists of glandular fluids. 60 to 70% of the volume originates from the seminal vesicles and 20% from the prostate. Therefore, the ejaculate of a man who has undergone a vasectomy is reduced by about 2%. Spermatogenesis. Spermatogenesis begins at puberty and continues for life. In this respect, spermatogenesis differs markedly from oogenesis, which occurs during fetal life only. Spermatogenesis takes place within the semi-inferius tubules of the testes. The basement membrane of each semi-inferius tubule is lined with diploid germ cells, called spermatogonia. These cells undergo continuous mitotic division. Some spermatogonia move away from the basement membrane and mature, becoming primary spermatocytes. These undergo meiosis, cell division that results in two haploid cells, called secondary spermatocytes. The secondary spermatocytes also undergo meiosis, resulting in four spermatids. The spermatids differentiate into spermatozoa, or sperm, each of which contain 23 chromosomes. So here you're taking a look at the semi-inferius tubule and the spermatogenesis. And then you're taking a look at a picture of mature sperm cells. Again, if I ever go too quickly, please hit pause. The development of the spermatids into sperm depend on the presence of Sertoli cells within the semi-inferius tubules. Spermatids attach themselves to the Sertoli cells from which they receive nutrients and hormonal signals needed to develop into sperm. The process of spermatogenesis from mitotic division of the spermatogonium to maturation of the spermatids takes about 70 to 80 days. Mature sperm migrate from the semi-inferius tubules to the epididymis, where their capacity for fertilization continues to develop. Although they are completely mature by the time they are ejaculated, the sperm do not become motile until they are activated by biochemicals in semen and in the female reproductive tract. So, male sex and reproductive hormones. The male sex hormones are androgens. Testosterone, the primary male sex hormone, and the other androgens are produced mainly by Leydig cells of the testes. The adrenal glands produce testosterone and other androgens in lesser amounts. In men, sex hormone production is relatively constant and does not occur in a cyclic pattern as it does in women. The physiologic actions of androgen are related to growth and development of male tissues and organs. Androgens are responsible for the fetal differentiation and development of the male urogenital system and have some effects on the fetal brain. After birth, the Leydig cells become quiescent until activated by the gonadotropins during puberty. Then, androgens cause the sex organs to grow and secondary characteristics to develop. Testosterone affects nervous and skeletal tissues, bone marrow, skin and hair, and sex organs. It has an anabolic effect on skeletal muscle tissue, thereby contributing to the difference in body weight and composition between men and women. Testosterone also stimulates growth of the musculature and cartilage of the larynx, causing a permanent deepening of the voice. Testosterone directly stimulates the bone marrow and indirectly stimulates renal erythropoietin production to achieve increased hemoglobin and hematocrit levels. Because sebaceous gland activity is stimulated by testosterone, acne may develop. In the presence of testosterone, hair becomes coarser in texture and facial hair, axillary hair, and pubic hair grow in male patterns. Testosterone is required for spermatogenesis and for the secretion of fluid by the prostate gland, seminal vesicles, and Cowper glands. Testosterone is also associated with an increase in libido. Other less understood effects of testosterone include regulatory proteins involved in glycolysis, glycogen synthesis, insulin action, and lipid and cholesterol metabolism. The regulation of androgen production and spermatogenesis is achieved by a complex feedback system involving the extrahypothalamic central nervous system, the hypothalamus, the anterior pituitary, the testes, and the androgen-sensitive end organs. These relationships, which are essentially the same in women, are summarized in Figure 24.3. Extra hypothalamic influences include such variables as psychologic and physiologic stress, which may inhibit or augment hypothalamic activity. In the hypothalamus, neurotransmitters regulate GnRH synthesis and pulsatile release into the hypophyseal portal veins. Norepinephrine stimulates GnRH secretion and serotonin, and dopamine inhibit GnRH secretion. GnRH is transported by portal flow to the median eminence of the pituitary gland, where it binds to receptors and stimulates the synthesis and secretion of the gonadotropins, LH and FSH. The gonadotropins are named for their effects in the female reproductive system, but have important effects on the male system as well. Your luteinizing hormone acts on the Leydig cells to regulate testosterone secretion. Your follicle-stimulating hormone acts on the semi-inferior tubule Sertoli cells to promote spermatogenesis. FSH secretion is inhibited by inhibin secreted by the Sertoli cells. Similar to their action in the female gonad, inhibin functions as an autocrine paracrine regulator in the male gonad. Inhibin inhibits proliferation of spermatogonia by regulating pituitary FSH levels. In addition, inhibin facilitates luteinizing hormone stimulation of androgen biosynthesis in the Leydig cells. 98% of testosterone, the major steroid hormone produced by the testes, binds to either sex hormone binding globulin, which is 40%, or albumin, 48%. The remaining 2% remain unbound in the plasma and is free to enter cells and wield its metabolic effects. Changes in the amount of available SHBG, or sex hormone binding globulin, affect the amount of testosterone within the tissues. The testes secrete only 25% of circulating estrogen. The majority is produced by peripheral conversion of testosterone and androstenedione. Estrogens help regulate GnRH and LH secretion. Peripheral conversion of the testosterone by 5-alpha reductase also produces a dihydrotestosterone, another potent androgen. Dihydrotestosterone, or DHT, is necessary for external viralization during embryogenesis and androgen activity beginning at puberty and continuing through adulthood. Prolactin, a polypeptide synthesized and secreted from the pituitary, helps maintain biosynthesis of testosterone. However, elevated prolactin levels may suppress biosynthesis. So, in summary, hormones secreted at each level of the hypothalamic pituitary testicular axis control and coordinate testicular function. This control is exerted through positive and negative feedback signals by 1. Sex steroids that inhibit hypothalamic GnRH secretion and pituitary LH responsiveness to GnRH, and 2. Testicular inhibin that inhibits pituitary FSH and possibly circulating estrogens. Any disruption along the HPT axis may lead to a hypogonadism or infertility. So here you're taking a look at the schematic representation of activity along the hypothalamus and pituitary testicular axis. A good spot to hit pause if you need to take a visual of how to see how those hormones regulate. Tests of reproductive function. Diagnostic tests of the male and female reproductive systems are performed to determine the cause of infertility, detect the presence of endometriosis or cancerous lesions, or help identify the presence of sexually transmitted infections. Tests of reproductive function are performed most commonly when infertility exists. Both partners are examined, and several diagnostic evaluations may be completed. The types of tests and their normal values are summarized in the following table. The man is evaluated for number, amount, structure, and motility of sperm, and obstruction along the reproductive tract. Tests for women determine whether 1. The reproductive tract, the cervix, uterus, fallopian tubes, is adequately patent to allow for passage of ovum and sperm. Ovulation occurs normally. The endometrium is responding normally to hormones, and reproductive tissues are free of tumors or infections. Hormonal assays evaluate the adequacy of pituitary function and target organ response. The position and size of organs or the presence of tumors can be detected by direct observation, procedures using a laparoscope or by ultrasound, radiographic studies such as plain films, CT scans, or tomography. So here's a good spot to hit pause if you need to review some of the tests and their normal values. Trying to make it so that it's easy to hit pause in all the specific spots. And then this table here shows your serum hormone values. Aging and the reproductive function. Aging and the female reproductive system. Natural menopause is the cessation of the ovulation and menses caused by ovarian failure. It is a normal development event marking the end of reproduction. Menopause is universally experienced by midlife women at the age of 50 to 51 years in North America, with variability between 40 and 60. Premature menopause is cessation of ovulation before 40 years of age. A number of factors are thought to influence the age of menopause, including genetics, socioeconomic status, race, parietal, oral contraceptive use, and lifestyle, such as smoking or vape. It can occur 2 years sooner on average for smokers. Thinner women also tend to experience menopause at a slightly younger age. Genetics accounts for about 50% of the variation in the age at menopause. The term climacteric refers to gradual changes in ovarian function that start before menopause and result in the symptoms associated with loss of ovarian function. For clarity, the sperm menopause will be used here. The primary changes of menopause are as follows. The perimenopause. This is a transitionary or transitional period between reproductive and non-reproductive years, a transition lasting anywhere between 2 and 8 years. About 5 to 10 years before menopause, and approximately 90% of women note mild to extreme variability in frequency and quality of menstrual flow. Changes in hormones occur during this time, including erratically higher estradiol levels, decreased progesterone levels, and disturbed ovarian pituitary hypothalamic feedback relationship with higher luteinizing hormone levels, a decrease in the sensitivity of the target tissue receptors, and the development of perimenopausal symptoms commonly are experienced. Symptoms usually begin with a lengthening of the menstrual cycle, which correlates with anovulatory cycles. Unpredictable or irregular ovulation uniformly precedes menopause. The perimenopause experience varies among women and from cycle to cycle in the same woman. Estradiol levels remain in the normal to slightly elevated range until about 1 year before menopause, leading us to menopause. Menopause is defined by the point that marks 12 consecutive months of amenorrhea and is determined retrospectively after a woman has not had a menstrual period for 1 year. It is characterized by the loss of ovarian function, low estrogen and progesterone levels, and high FSH and LH levels. Early menopause is the 5 years after menopause onset. Late menopause follows and continues until death. So here you're taking a look at a hormonal chart and how it changes during menopause. Ovarian changes beginning in utero. The number of follicles steadily decrease through activation, maturation, and atresia. Around 37 to 38 years of age, women experience accelerated follicular loss, which ends when the supply of follicle is depleted at menopause. This accelerated loss is correlated with increased FSH stimulation, slightly elevated estradiol levels, declining inhibin B production, and decreasing amounts of anti-Müllerian hormones. Attenuated luteinizing hormone surges are associated with impaired hypothalamic responses to estradiol-positive feedback. The ovarian response to high FSH recruits increasing numbers of follicles. These follicles only partially develop, with a net effect of irregular ovulation, lower progesterone levels, depleted follicle reserve, and infertility. The ovaries begin to decrease in size around age 30. This decrease accelerates after age 60. Of the 500,000 follicles present at the onset of puberty, the number dwindles to between 100 and 1,000 with menopause. Table 24.6 summarizes endocrine events occurring during the perimenopause. The table following that provides a template to visualize the complex physiology of the perimenopause and the dynamic changes that occurs during this time. So it's a good spot to hit pause so you can see the changes in the ovarian folliculogenesis during perimenopause, leading to endogenous overstimulation. And then here is that other table of endocrine events associated with perimenopause. So here's a good spot to hit pause to see the endocrine events associated with perimenopause. And then the postulated perimenopausal transition timeline. So a couple spots to hit pause here. See if I can get it all on one slide. Almost. Uterine changes. Uterine changes occur primarily in the endometrium. The increase in the anovulatory cycles allows for proliferative growth of the endometrium. The longer exposure to estrogen alone results in greater thickness of the endometrium, and 50% of the perimenopausal women will experience dysfunctional uterine bleeding that is heavy and unpredictable. Increased endometrial bleeding is correlated with a change from ovulatory to anovulatory cycles and is associated with unopposed high estrogen levels the week before menses. Estrogen causes endometrial tissue to thicken. However, without corresponding stromal support from progesterone, estrogen production leads to heavier periods, menometriohagia, or metrohagia. In the past, this has put women at high risk for hysterectomy or endometrial ablation. Medical and hormonal management is the first line of therapy if the uterus is normal. So this following table here shows the impact of high estrogen levels on the menstrual cycle and its symptomatology. A good spot to hit pause and review. Breast tissue changes. Glandular breast tissue becomes involuted. Fat deposits and connective tissue increase, and breasts are reduced in size and firmness. There can be an increase in white adipose tissue inflammation with elevated aromatase levels. The genitourinary tract changes. The ovaries shrink, the uterus atrophies, and the vagina shortens, narrows, and loses some of its elasticity. Lubrication of the vagina diminishes and vaginal pH increases, creating higher incidence of vaginitis. The cervix atrophies and the cervical os shrinks. Vaginal epithelium atrophies, the labia majora and minora become less prominent. Some pubic hair is lost. Urethral tone declines along with muscle tone. Throughout the pelvic area, urinary frequency or urgency, UTIs, and incontinence may occur. Regular sexual activity and orgasm may diminish. Some of these changes. Sexually active women have less vaginal atrophy. Skeletal changes. Bone mass is reduced, leading to increased brittleness and porosity, which increases the risk of osteoporosis and fracture, particularly in the lumbar spine and femoral neck. Cardiovascular changes. The risk of cardiovascular disease increases significantly and is the leading cause of death in postmenopausal women. Blood pressure and total and LDH cholesterol increases, and HDL cholesterol decreases. There is increased risk for metabolic syndromes. Systemic changes. Vasomotor flushes are characterized by a rise in skin temperature, dilation of peripheral blood vessels, increased blood flow in the hands, increased skin conductance, and a transient increase in heart rate, followed by a temperature drop and profuse perspiration over the area of flush distribution. This usually occurs in the face and neck and may radiate into the chest and other parts of the body. Night sweats, dizziness, nausea, headache, or palpitations may accompany the flush. These flushes can vary in frequency, intensity, and duration, and are experienced by up to 85% of the perimenopausal to postmenopausal women from 1 to 15 years. The physiology of vasomotor flushes is poorly understood. One theory proposes that rapid changes in estrogen levels may result in loss of negative feedback over the hypothalamic noradrenal synthesis, the primary neurotransmitter involved in thermoregulation. Estrogen modulates adrenergic receptors. The decrease in estrogen level in menopause is thought to decrease the number of receptors, leading to increased noradrenaline levels and hot flushes. Interestingly, emerging evidence show that the intensity of vasomotor flushes may be associated with increased risk for cardiovascular disease. Any other changes? Well, emotional stress with unpredictable mood swings, weight gain, migraine headaches, insomnia, and depression often accompany the changes in estrogen levels. Lower estrogen levels decrease skin thickness and diminish skin elasticity, thereby causing increased skin dryness and wrinkling. Alopecia and unwanted facial hair are common. That leads us to aging and the male reproductive system. Men maintain reproductive capacity longer than women. There is no known discrete event comparable to menopause that characterizes the aging of the male reproductive system, although the term andropause is sometimes used to describe the changes associated with male aging and lower levels of estrogen. Gradual changes do occur, and aging in the male reproductive system is characterized by the hypogonadism, testosterone deficiency, erectile dysfunction, and proliferative disorders of the prostate glands. Aging changes are also influenced by chronic disease and the use of medication. Components of male sexual behaviors include both sexual drive and erectile and ejaculatory capacity. Libido, or sexual drive, is the complex phenomenon that requires a baseline hormonal milieu, but is influenced significantly by health status and environmental, social, and psychological factors. In men older than 40 years of age, organic factors and chronic disease are involved in more than half of the cases of male sexual dysfunction. Aging causes specific physical changes that may influence erectile and ejaculatory capabilities. Alterations in sexual response include the need for longer stimulation to achieve full erection, slower and less forceful ejaculation, with less pelvic muscle involvement, decreased vasocongestive response, and longer refractory periods, up to 24 hours in some men. The testes undergo several age-related structural changes, including decreased weight, atrophy, and softening. Degenerative changes in the seminiferous tubules may include thickening of the basement membrane, increase in lumen size, germ cell, arrest, and a decrease in spermatogenic activity, and a collapse of tubules, followed by complete obstruction, caused by sclerosis and fibrosis. Areas of mild to severe degenerative changes may be interspersed with areas having intact tubules. These morphologic changes may result from atherosclerosis in the testicular vascular bed. Alterations of the seminiferous tubules do not appear to diminish sperm count, but they do reduce fertility because a greater percentage of sperm lack motility or have structural abnormalities. About 20% of healthy men more than 60 years of age and 30% to 50% older than 80 years of age have testosterone levels below the reference range, and about 2% have hypogonadism. Aging can cause changes in the reproduction of male sex hormones, levels of SHBG, and responsiveness of target tissue receptors. Hormone synthesis by the testes and testicular responsiveness to the gonadotropins are diminished, and the pituitary secretion of these gonadotropins is elevated. The reduced levels of testosterone may be related to alterations in the Leydig cells, the testosterone producers of the testes. The number of the Leydig cells and their function decrease as age increases, perhaps because of decreased arterial perfusion of the testes. The varicocele and decreased luteinizing hormone or responsiveness to LH. Even if testosterone levels are not decreased, older men may have less unbound testosterone in their blood, decreasing the number of unbound hormone available to stimulate target tissues. Decreased testosterone levels have several effects, including functional deterioration of the accessory sex organs, loss of muscle mass, strength, and endurance, increased visceral fat, osteopenia, and cognitive decline, and in many men, decrease in libido. This last effect also may be caused by alterations in other variables that affect libido. Modifiable risk factors for low testosterone levels and symptoms of androgen deficiency include health status and waist circumference. This concludes our chapter here today, and I'll see you all at the next one. Until then, I hope you have a wonderful day. Take care and goodbye.